Welcome to the deep dive. You're here to sharpen your knowledge of atypical pneumonia, specifically for the MSRA, and that's exactly what we're going to do today.
Absolutely. We've sifted through the essential information.
Yeah, to give you a really high-yield breakdown of this key condition.
Consider it your focused revision session. We'll cover it all.
From what it is, the causes, right through to management, and we'll throw in some memory hooks as well, things to help make it stick.
Definitely. And we're focusing on those core pathogens you need to know: Mycoplasma pneumonia, Legionella pneumophila, and Chlamydia pneumonia. So let's get started.
Okay, so to kick us off then, what exactly is atypical pneumonia? How do our sources define it?
Well, at its heart, atypical pneumonia is a lung infection caused by atypical pathogens. That's really the key thing.
Atypical pathogens.
Yeah, and it's often contrasted with typical pneumonia, the kind usually caused by Streptococcus pneumonia.
Which tends to be more sudden, more severe.
Exactly. Atypical usually comes on more gradually. The symptoms are often milder, and you might see different patterns on a chest x-ray too, not always that classic lobar consolidation.
Okay, milder symptoms, slower onset, maybe different x-ray findings. Got it. So let's nail down these atypical pathogens. Who are the main culprits we need to remember?
The big three are definitely the bacteria: Mycoplasma pneumonia, Legionella pneumophila, and Chlamydia pneumonia.
Right.
But it's important to remember the sources also mention that respiratory viruses like influenza, RSV, they can cause community-acquired pneumonia too.
Okay.
And even Streptococcus pneumonia, the typical one, can sometimes present in a way that, seems a bit atypical at first.
Right. So it's not always clear-cut. We focus on the main three atypical bacteria, but need to keep in mind that other things can sort of muddy the waters a bit.
Precisely.
Okay. Now, thinking about who gets this, what are the risk factors? What makes someone more likely to develop atypical pneumonia?
Well, there are several things. Close contact with someone who's already infected is a big one.
Makes sense.
Especially in crowded settings, like communal living, think student halls, military barracks, prisons. Environmental factors also play a part. Smoking, definitely. Even secondhand smoke exposure.
Irritates the airways.
Yeah, exactly. And like many infections, having a weakened immune system increases your risk.
Right. Immunocompromise.
And age is a factor too. Both ends of the spectrum, young children and older adults seemed to be more vulnerable.
Okay, so crowded places, smoking, weakened immunity, and the very young or old. That makes sense. Now, are there specific ways these different bugs spread? You mentioned the big three.
Yes, there are some key differences. Mycoplasma and Chlamydophila, they mainly spread person to person.
Droplets.
Yeah, usually through respiratory droplets. So coughing, sneezing in closed environments like schools, offices, that's prime territory for them. Explains those little outbreaks you sometimes see.
Okay, person to person for those two. What about Legionella?
Legionella is different. It's environmental. It lives in water sources.
Like natural water.
Yeah, fresh water, but also, importantly, man-made water systems. Think air conditioning cooling towers, hot tubs, showers, fountains. Infection happens when people breathe in tiny water droplets, aerosols, that are contaminated with the bacteria.
So not usually person to person for Legionella.
Not typically, no, it's the water source.
That's a really important distinction for exams, person to person versus environmental source.
Right. Now let's think about what these pathogens actually do once they're in the body. The pathophysiology.
Okay. So these atypical pathogens, they primarily target the cells lining our airways, the respiratory epithelium.
They infect those cells.
Yeah, they invade them, and that triggers inflammation. That inflammation then leads to lung tissue damage.
Okay.
But what's interesting is that the immune response, generally speaking, seems to be a bit milder, maybe less aggressive, compared to the really strong response you often get with typical bacterial pneumonia, like from strep pneumo.
Ah, okay.
Yeah.
That might explain the milder symptoms sometimes. Potentially, yeah. And again, the main ones we're talking about here are Mycoplasma, Chlamydia, and Legionella.
Got it. Are there any other organisms, maybe less common ones, that can present similarly, ones we should be aware of for, say, a differential diagnosis question?
Yes, definitely. The sources mention a couple of others worth knowing. There's Chlamydophila psittaci.
Psittaci. That sounds like birds.
Exactly. It's associated with exposure to sick birds. So think parrots, pet birds.
Okay, the parafever bug.
Right. Then there's Coxiella burnetii. That causes Q fever, often linked to exposure to farm animals like sheep or cattle.
Farm animals for Coxiella.
Okay. And crucially, don't forget viruses. Lots of viral pneumonias can look very similar initially. Influenza A, obviously SARS-CoV-2, RSV, adenovirus, even chickenpox virus, varicella, can cause a pneumonitis.
Wow, okay. So the list of mimics is quite long. Birds, farm animals, and lots of viruses.
Need to keep those in mind.
So when we see a patient and we're thinking maybe atypical pneumonia, what else needs to be on our differential diagnosis list for the MSRA? What are we trying to rule out?
Well, the big one is typical bacterial pneumonia, usually strep pneumonia. You need to compare the presentations. Remember, typical often has that more acute onset, higher fever, maybe productive cough, signs of consolidation.
Go typical versus atypical bacteria first.
Then, as we just mentioned, viral pneumonia, influenza, RSV, others, big overlap in respiratory symptoms.
Right, very common.
Tuberculosis, don't forget TB. It can be insidious, chronic, but it's a bacterial lung infection.
Good point. TB.
And maybe a lung abscess? That's a localized collection of pus, usually bacterial, but it presents differently clinically and on imaging.
Okay, so typical bacterial, viral, TB, lung abscess. That's a solid list of differentials. Now, how common actually is atypical pneumonia? What's the epidemiology like, say, in the UK, based on our sources?
Well, the sources suggest that getting an exact prevalence figure is tricky. It's not perfectly defined. But we know it affects all age groups. However, there does seem to be a higher incidence in children and young adults.
More common in younger people, then?
Tends to be, yeah. As a ballpark figure, maybe around 20%, 1 in 5 cases of all community-acquired pneumonia could be caused by these atypical organisms.
20%. Okay, that's significant. Definitely something we need to be comfortable with.
Absolutely.
So how does it usually present? What are the classic clinical features that should make us think this could be atypical?
The key thing often is the gradual onset. Symptoms tend to develop over days, sometimes even weeks. It's not usually that sudden hit by a bus feeling.
Gradual onset. Okay. What kind of symptoms?
Common respiratory ones are a cough, often dry, maybe non-productive initially, some mild chest discomfort, and usually a low-grade fever, not necessarily raging temperatures.
Dry cough, mild discomfort, low fever.
And patients often feel generally unwell systemically. Headache is common, fatigue, that general sense of malaise, just feeling off.
Right, the systemic stuff too. Headache, fatigue. Now, you mentioned earlier that the different atypical bugs can sometimes have slightly different flavors. Can we dig into those specifics, starting with Mycoplasma pneumonia?
Sure. So Mycoplasma, again, typically gradual onset, fever, headache, that dry cough we mentioned. Muscle aches, myalgia, and fatigue are really common too.
Okay.
And it can drag on, sometimes takes weeks to fully resolve. But the really key thing for Mycoplasma, for exams especially, is its potential for extra respiratory features.
Parts like the lungs. Like what?
Things like skin rashes, erythema multiforme is classically associated, neurological problems, encephalitis, meningitis, joint pains, arthralgia, and even rarer things like pancreatitis.
Wow. Okay, so it can affect lots of systems. Is there a memory aid for that?
Yeah, you could think. Mycoplasma? More than just lungs?
Mycoplasma? More than just lungs. I like it. Okay, what about Chlamydophila pneumonia?
Chlamydophila also tends to be gradual, maybe a bit variable in how it progresses. You might get upper respiratory symptoms, first sore throat, runny nose before the cough really kicks in.
Okay, it starts like a cold sometimes.
Could do. Hoarseness is quite characteristic with chlamydia pneumonia. Headache is common too. Fever is often less prominent, maybe low-grade or absent.
Hoarseness and headache are key then.
They're good clues, yeah. And frustratingly, the symptoms can really persist. Weeks, sometimes even months.
Months. Wow. Memory tip for that one.
How about chlamydia? Cough, hoarseness, hangs around.
Chlamydia. Cough, hoarseness, hangs around. Good one. Right, finally, Legionella pneumophila. You said this one can be more severe.
Yes. Legionella often presents more acutely, more like a severe pneumonia. High fever is typical, significant headache, bad muscle aches.
Sounds rough.
It often is. The cough is usually present, might be productive. Shortness of breath, dyspnea, and pleuritic chest pain are common. And really importantly for Legionella, look for gastrointestinal symptoms.
GI symptoms like what?
Diarrhea, nausea, vomiting. Pretty common with Legionnaire's disease.
Okay. Gut involvement is a clue. Anything else?
Yes. Neurological complications are also a feature confusion, altered mental state. Joint pain can occur. And like Mycoplasma, rare but serious things like pancreatitis are possible.
So more severe, high fever, gut symptoms, neuro symptoms, joint pain. How can we remember that?
Maybe. Legionella. Looks bad, gut involved, plus neuro and joint signs.
Legionella. Looks bad, gut, neuro, joint. Okay, those mnemonics are really helpful. So when we're examining a patient we suspect has atypical pneumonia, what should we focus on? What signs might we find or not find?
Well, obviously you check the vital signs, temperature, heart rate, respiratory rate, SATs, but specifically you need to look for those extrathoracic signs we talked about, rashes, confusion, joint issues.
Right, the more than just lung stuff.
Exactly. Interestingly, the chest exam itself can be quite unhelpful sometimes. You might not hear those classic crackles or signs of consolidation that you expect with typical pneumonia. Findings can be subtle or even normal.
So the chest exam might be misleadingly normal.
It can be, yes. So we're also looking for any signs of complications affecting other organs. But really, the history, that gradual onset, the specific symptom clusters for each bug, that's often more revealing than the auscultation findings alone.
The story is key. Got it. So what about investigations? How do we try and confirm the diagnosis?
Okay, the sources mention a few approaches. Blood tests are usually done, FBC to look at white cell count, inflammatory markers like CRP, ESR. They're non-specific, but give you a general picture of inflammation.
Standard bloods.
Sputum culture and analysis. We try to identify the organism, but these atypical bacteria can be really difficult to grow in the lab, so a negative sputum culture doesn't rule them out.
Right. Culture isn't always helpful then. Imaging.
Yes. A chest x-ray is standard, looking for infiltrates, consolidation. As we said, in atypical pneumonia, the pattern might be different, often more patchy interstitial infiltrates rather than dense lobar consolidation, but it can vary.
Patchy X-ray findings.
Okay.
Any specific tests for these bugs?
Yes, for Legionella, there's a urinary antigen test, which is quite useful and relatively quick. There are serology tests for antibodies against Mycoplasma and Chlamydia, but they often take time for antibodies to develop, so they're not great for diagnosing acute illness.
Okay, so bloods, tricky sputum, maybe a patchy X-ray, and specific urine test for Legionella.
Right.
How do we actually manage these patients in the UK?
Management revolves around antibiotics that cover these atypical pathogens, because standard beta-lactams like penicillin or amoxicillin often don't work well against them.
So what do we use?
First-line options are often doxycycline or a macrolide antibiotic like azithromycin or clarithromycin. Erythromycin is another macrolide option. Fluoroquinolones like levofloxacin or moxifloxacin are also very effective alternatives.
Oxy, macrolides, fluoroquinolones. Got it. And supportive care too, presumably?
Oh, absolutely. Supportive care is vital. Rest, plenty of fluids for hydration, managing fever and pain with simple analgesics like paracetamol or ibuprofen.
Standard stuff. When would someone need hospital admission?
Usually if the illness is severe, maybe low oxygen levels, signs of sepsis, confusion, or if they have significant underlying health conditions, comorbidities that put them at higher risk, or if they can't manage at home.
Okay. Severity and comorbidities guide admission. Any other management points from the sources?
Yeah, a couple of things. Routine serology testing, as I mentioned, isn't generally recommended for diagnosing acute community-acquired pneumonia. It doesn't usually change immediate management.
Right.
There's also a growing concern about macrolide resistance, particularly for Mycoplasma. Something to be aware of. It might affect your choice of antibiotic in some areas or if initial treatment fails.
Macrolide resistance. Important point.
Hmm.
Anything specific for severe Legionella?
Yes, for severe Legionnaire's disease, guidelines often recommend combination therapy, maybe a fluoroquinolone or azithromycin plus rifampicin.
Rifampicin added in for severe cases.
And just worth remembering that fluoroquinolones have broad coverage.
Yeah.
They hit typical bacteria like strep pneumo as well as the atypicals.
Useful if you're unsure, perhaps. Okay, so what's the usual outcome? What's the prognosis like for atypical pneumonia?
Generally, it's good. For most people who get the right antibiotics, they make a full recovery. It might take a few weeks, but they get there.
That's reassuring.
Yeah, but of course, if the illness is very severe to start with, or if the person has other significant health problems, or if they develop complications, then the recovery can take longer and the risks are higher.
Makes sense. And speaking of complications, what are the main ones we should know about, even if they're not common?
Well, like any pneumonia, it can potentially lead to respiratory failure, needing ventilation support.
Oh.
Pleural effusion fluid collecting around the lung can happen. A lung abscess, that localized pus collection, is pretty rare with atypicals, but possible.
Abscess rare.
And also rare, but very serious, is acute respiratory distress syndrome, ARDS. That's severe lung inflammation.
Right, ARDS is the really bad one. So respiratory failure, effusion, rare abscess, rare ARDS. Good to have those on the list.
Okay, so just to quickly summarize for everyone revising for the MSRA, atypical pneumonia, Usually a milder, more gradual onset than typical pneumonia. Key causes are Mycoplasma, Legionella, Chlamydia pneumonia. Remember those distinct features in our mnemonics?
Mycoplasma, more than just lungs.
Chlamydia, cough, hoarseness, hangs around.
And Legionella, looks bad, gut, neuro, joint. Yeah.
Exactly. Consider the differentials: typical bacterial, viral, TB, abscess. Investigations include bloods, chest x-ray, often patchy, maybe specific tests like the Legionella urinary antigen.
And management relies on antibiotics like doxycycline, macrolides, or fluoroquinolones, plus supportive care. Prognosis generally good, but be aware of potential complications.
Perfect. Focusing on those nuances, the gradual onset, the extrapulmonary features, the right antibiotics, that's going to be key for your revision.
Definitely. Hopefully this run-through helps it all make sense. Excellent. We hope this deep dive has given you a clear, high-yield, and memorable overview of atypical pneumonia for your MSRA prep.
And for more resources, loads of practice questions, and other great revision material.
Do check out pastthemsra.com.
And also freemsra.com for, well, free MSRA questions.
Couldn't be clearer. Thanks for joining us on the deep dive.